Okay, continuing with slide 37, where we left off in our last segment, we're going on to talk about special health records. Some health records have unique requirements because of the specialized service that is provided. Examples are obstetric and newborn. The mamas and the babies, right? Okay, let's start with moms or the obstetric gynecology records. You're going to have a medical history, including any history of abuse, neglect, or sexual practices, because they can impact that patient's care. It shows what type of certain sexual behaviors or abuse or neglect or what have you might put them at risk for certain things, okay, for certain diseases or increase their risk of different things. It also helps them to know what to look for. If they have a history of abuse, then they will continue to look for signs of that abuse, to offer assistance or neglect, or like if they are pregnant and they are in their 8th month or 9th month before they even seek any type of obstetric care, that's documented because those things are important. If they have promiscuous sexual practices, then they are at a higher risk for sexually transmitted diseases, for example. Okay? There will also be periodic routine laboratory testing, perhaps pregnancy tests would be in there, checking for anemia, different blood work, perhaps checking hormone levels and things like that. Additional laboratory testing for high-risk groups, such as patients that might have need tuberculosis, skin testing, and testing for an STD, a sexually transmitted disease. In the newborn record, the moment the infant is born, they receive their own special health record. Okay? So then, while they are still in the womb, everything's in the mama's record. But once they're born, then they get their own health record. Okay? Right there at the time of birth. The examination is performed at birth and at discharge. And there's something called the APGAR score that they assign to infants, and they test them on these different points. And they assign a score, okay, from 0 to 10 on the APGAR score. And you'll learn more about that, I believe, in medical terminology. And we may even touch on it in here some more. In the emergency department record, we have EMTALA, EMTALA, and they must stabilize the patient in emergency. And EMTALA also prevents or prohibits healthcare providers from refusing to treat patients or delaying treatment due to their inability to pay. Okay? And I'm not really sure why that cut off here, but it sure did. They might stabilize them and transfer them on, but they can't just say, hey, I'm sorry, you can't be seen here, just because they are, unable to pay in an emergency situation, okay? The emergency department or record itself is sometimes incorporated within the inpatient record, and at other times it's kept separately. It depends on the healthcare organization and their policies and procedures, okay? So it might all be kept in one centralized record, or they may have their own separate records. The emergency department record includes the arrival time, the means of arrival. Were they able to walk in ambulatory by themselves? Were they brought in by a family member? Did they arrive by ambulance? How did they get here? Did the police bring them? Okay. And the name of the person that's bringing the patient to the emergency department. Okay, so that's important. Disposition of the patient. Okay, were they discharged to the hospital and admitted into the hospital? Were they discharged home? Were they transferred to another facility? Anytime you've got an admission, whether in the emergency room or to the hospital, you have to say where they were discharged to. Did they leave AMA against medical advice? We've talked about that before. We need to know where they were discharged to. The condition of the patient on discharge. Were they still disoriented? Were they drugged to where they weren't able to drive and needed someone to drive them home? Did they, the name of the person that brought them to the emergency department, do we need to call them to, from the waiting room to walk them out? Do we need to, if the person is by themselves, do we need to stabilize them and make sure they're able to walk better if they're having to drive? Do they need a cab because they can't drive? Different things. Is this a homeless person? We need to know where they're going and the condition on discharge. An ambulatory record. Boy, this came through awfully small. The ambulatory records contain registration forms, problem list, medication list, the patient history questionnaires. I'm sure you've all filled those out if you've been to a doctor before, right? The history and physical that the physician given, the progress notes, the results of the consultations, if there were any diagnostic test results, if they were performed, including, lab work or what have you. Miscellaneous flow sheets. For example, a pediatric growth chart would be in a child's record, and immunization records, and specialty specific flow sheets would be in an ambulatory record. It might be physical therapy records or something. Copies of records from the previous hospitalizations or treatment by other healthcare practitioners or facilities. Correspondence where perhaps on discharge a letter was sent to the family practice physician of the patient. Consents to disclose information, all of those should be, copies of that should be in the record. Advance directives, if one was signed, would be in the record. An ambulatory surgery record. Okay, remember ambulatory, we think typically they're able to ambulate, they're able to walk, okay? You're going to have documentation of the surgery. All records, the records to call the patient 24 to 48 hours after discharge to do that follow-up and make sure they're doing okay. That's documented in that record. Ancillary departments. Ancillary would be like radiology, lab, pharmacy, those outerlying departments, okay? Those are ancillary. They supplement the care, is what I always think of. That's the documentation of the test and the treatments performed. A physician office record. You're going to have documentation in that record to include the medical history, the family history, the social history, vital signs, the chief complaint, a progress note every time the patient is in there, right? Any known allergies or reactions to medications, medication list, what the patient's been on in the past, what they've been on in the present, if they've been seeing this physician for a number of years or what have you. And that's a continual medication list, we should say, because they can look back and say, oh, I see last year you were treated with amoxicillin. What was that for? Or I see you had steroids. You were on steroids a number of times last year for respiratory problems. Let's evaluate this, that type of thing. Let's see, we've got medication list, history of present illness, tells what's going on with the patient right now, today. Why are we seeing the patient today? Review of systems, going from, the skin, the respiratory, checking digestive, different things like that. They go through the body systems that pertain to the present illness. Then they have an assessment and a diagnosis, and then they have a plan of treatment. Long-term care, it contains ongoing assessments, a resident assessment instrument, which is their minimum data set. You know how we had the Uniform Hospital Discharge Data Set, the UHDDS, for acute care records? Well, we have the resident assessment instrument in long-term care records. And then we also have the treatment plan and typical health record documentation. In rehabilitation records, the documentation varies based on whether it's an inpatient or an outpatient setting, but it also includes, for either one, the diagnosis of the disability and the functional diagnosis, the rehabilitation problems, goals, and prognosis, and then the typical healthcare health record documentation. In behavioral health, it's going to also contain a treatment plan. It's going to have a social worker's assessment and documentation of the family or home environment and community services available. For instance, if the patient is in an abusive home environment, they take that into consideration. Maybe the patient has been in for drug treatment or whatever, and the home environment is such that maybe they're living with people that are actively on drugs or whatever. They're looking at that. Then a psychiatric evaluation would be in there. And then, again, the typical health record content. Health information media, we've already talked about this a number of times, but we're reviewing a little bit each time as we go through it while we're going in more detail. Remember that I talked about it could be in a paper format. It could be hybrid, where it's part electronic and part paper, or it could be totally electronic. In the paper health record format, we have this source-oriented health record. And yes, you need to know the different types and know what the components of these are. The source-oriented health record, we have the universal chart order for that at that facility. It's pretty much it's a list that tells you the face sheet will be first, the history and physical will be second, the discharge summary will be next, the physician's orders will be next, or the consults will be next, and then the physician orders, or it lists exactly what order to put the record in. Okay, that's called chart order. Now, in most facilities, they do a paper record in reverse chart order. Okay, reverse chart order is where, or reverse numeric. Okay, you're going in. The oldest would be on the bottom, and the most recent would be on the top. Okay. And then we have an integrated health record, and we have a problem-oriented medical record. And in the problem-oriented medical record, they do what is called a SOAP. SOAP is the acronym. And that stands for subjective, objective, assessment, and plan. Okay, and you do need to know these and read more about these because you will be tested on them. Okay, just going a little more detail on SOAP. The way I remembered it, you've got the letters there to remind you of the actual words: subjective, objective, assessment, and plan. I always think subjective. That's what the patient says, okay, is wrong. The patient says, I have abdominal, I have a tummy ache, and my head hurts, and I'm achy all over. Okay, subjective. Objective is the physician examining. In my head, S stands for the patient says for subjective. Objective They're looking at the object, which is the doctor looking at the object, which is the body, and giving the examination. You know, if the stomach is hurting, they're going to palpate the stomach and see exactly where it's hurting, how tender it is. If the patient is complaining with the sore throat, they're going to look into the mouth and see, oh yeah, it's red, it has blisters in there, blah blah blah, the tonsils are swollen or whatever. That's what they're seeing on examination. Okay? And then assessment is where they're assessing all of that. They're assessing what's going on with the patient. This is my diagnosis. Okay? They're making their assessment. This is my diagnosis. Assessing the situation, what the patient's saying, my objective examination, and I assess it and I say, this is what's wrong with the patient. And then this is my plan of care. I plan for more testing. I plan for to put the patient on antibiotics. I plan to do surgery. Okay? I hope it all makes sense. Now, the electronic health record advantage is that you have point of care documentation. I can tell you that the last time I was admitted to the hospital, they had computerized computers at the bedside, and the physician would come in and do his examination, talk to me, and then he would document in the record electronically. Okay? And when the nurses came in to do their vital signs and check on me and all of that stuff, or give me medication, they would enter that in the record at the bedside. Okay? And then, of course, it's captured electronically, but it's at the point of care being wherever the patient is. Okay? Web-based document imaging is where we capture, digitize, integrate, store, and retrieve paper-based health record documentation. So they scan those records in, the paper record in, and then it's stored electronically out there on the web with, of course, special privacy and security going on to meet all requirements. And then an authorized person can access those records to print or review those records. Okay, so it's web-based. And then it organizes and assembles the paper-based record documentation, and it controls the versioning and access and search capabilities of the documentation. Now, when they scan these records in, they use the barcoding. And if you think about it, a barcode, when you go to the store, is on just about everything, right? They scan it. That's what they do. And so when it comes to a medical record, they each form in a medical record will have a barcode, okay? And that barcode will identify that as a progress note or physician's order or, what have you. And as it's scanned in date order, then it will sort it into whatever category it needs to go in. Like, it would put all of the physician's orders under physician's orders, and if it's scanned in date order, they would be in date order. Make sense? Okay. Then we have the role of the healthcare professionals in documentation. And we have a number of different roles. Quality documentation is paramount to patient safety, the quality of care provided to those patients, and also appropriate reimbursement. So we are the keeper of the health record, okay? And as such, it's our responsibility to make sure that it's retrievable, that all the documentation is there, and to assist with that, and make sure that when that record is needed for whatever purpose, whether it be legal or release of information or research or what have you, whatever the appropriate um, avenue is, we are the keeper of the record. So that's our responsibility. Physicians document appropriately. Ideally, they document appropriately so that the quality of care can be rendered and that appropriate reimbursement can occur. And you can't just tell a physician, I need you to write this in the record so we'll get paid more, or what have you. That is called leading, and that's a big, big no-no. And they will be the first to tell you that. One of the first. Okay, so you have to be careful in that communication and how you ask and what you're asking for. Documentations within the health record impacts the patient as well as other physicians. Nurses' documentation varies by their licensing and regulatory requirements, the setting that it's in, and internal policy and procedures. And the, excuse me, allied health professionals, many follow treatment plans that are developed by the patient's physician or a therapist or a technologist, and then documents the treatment and the patient's response to that treatment. For instance, if the physician orders the patient to be put on a ventilator for respiratory support, then you're going to have documentation by the respiratory therapist. You're going to see documentation of the ventilator support, how checked it, adjusted, made any adjustments, how many hours, because documentation is payment, and it also gives the healthcare providers an idea of what's going on with that patient. If the patient, for instance, is in the intensive care and on a ventilator support and all that, and they've only been off of ventilator support a few days, when they're discharged to another facility, it's very important that that documentation of what's been going on with that patient is in that record, right? And then health information management plays a vital role and different roles in the overall governance of the health record information. We have a part in documentation improvement and training on documentation. Typically, we have input of that. Manages many aspects of the health record and its content. If something is not working documentation wise or what have you, then a lot of times we are also brought in on those meetings to discuss it. If a new form is used by a department, we have to be brought in on that to make sure the form will work in the system and to make sure that health information management staff know where to put that form when they receive it, okay? In the record or what have you, okay? And it manages many aspects of the health record and its content, and the roles are more information technology focused now. IT is information technology focused now than they have ever been. And with that said, we're going to conclude this lesson.